everything in place. And these are the little sponges that will hold the skin graft against the bone where it will take its blood supply. So when they get wet with the antibiotic solution, they expand. The next step is to make the opening in the outer part of the ear. Once I've made that opening, I then deliver the skin graft through the opening. So now there's the skin graft, and it's going to be brought out through the opening. You can see the little sponges right here. I'll trim the excess skin graft, and now sew the edge of the skin graft to the patient's own skin at the opening. Put more of these sponges in. So here it looks with a grade 3 microtia before the MedPore. This is the fascia graft covering the ear bones. Here's the skin graft placed in. And then here are the sponges. The MedPore surgeon will then build the outer ear around the canal. I keep the children in the hospital one night after surgery. They're on antibiotics. Take the dressing down the day after surgery. The parents just change the cotton ball with some ointment once a day. They have to keep the ear and the arm or the leg dry. 1 week after surgery, I take those little sponges out. I take out any sutures, but all the sutures are dissolvable. We put the patient on antibiotic ear drops and still keep the ear dry. So remove the packing 1 week after surgery. So 1 month after surgery, I have to clean the ear of the dead skin. We do our first hearing test, and the child will need to have the ear cleaned once or twice a year forever. The cleaning simply involves removing the dead skin, and it's not painful to the child. But it has to be done under the microscope by an ENT. A pediatrician could not do this. And so after the cleaning, we have a nice ear canal, and you can see the eardrum. We do a hearing test, and so if the surgery has gone well, the hearing thresholds can many times be brought into the normal range. So the hearing results after surgery. I looked at 116 ears that I operated on and looked at the different Jarsdorfer grades based on that CT scan. Remember, the higher the score, the better the anatomy. In children who were 6 and below, there was only a 45% chance of giving them normal or near normal hearing. In children who scored 7, 8, or 9, there was an 80 to 90% chance of giving them normal or near normal hearing. So the hearing results really do depend on the anatomy of the middle ear. The complications of surgery, nerve loss in about 5% or less. The hearing doesn't get much better, and they still have a conductive hearing loss. I tell families I can never make the reconstructed ear as good as a normally developed ear, but I hope to get the hearing in the normal range in the human voice frequencies. Facial nerve injury is very, very rare. This is narrowing of the canal. I make a beautiful canal, and over time it closes shut in about 15 to 20%. But there are several things I can do to prevent that from happening. During puberty, many children will have new bone in the canal, which is okay. All the complications, narrowing of the ear canal is the most common. To avoid that problem, I inject steroid in the skin around the opening and use a foam earplug at night while the child sleeps to prevent closing. So remember, the child will need to have the ear cleaned once or twice a year forever. I think in the interest of time, I might just skip forward and talk about the canal versus the bone conductor. So the canal is difficult surgery. There are complications. The hearing outcomes are variable. The bone conductor is much easier, there are minor complications, and there's excellent and predictable hearing. So in this study, the canal surgery with a hearing aid were comparable to the Baha results. This study looked at a number of canal surgeries and Bahas, and the hearing results in Baha are better. But I think with canal surgery, they're able to locate sound better in space and hear better in background noise. So these again are the options: observation, bone conducting hearing device, the implantable or osseo-integrated bone conducting device, and canal surgery. I want to leave you with one other important point that I have brought out in our research, and that is the role of fatigue. Children with hearing loss are tired and need rest. So finally, I'm trying to optimize or make better my surgical outcomes. Looking at the middle ear anatomy, as I told you earlier. I'm looking at the angle between the second and third ear bones. And I'm always wanting to improve my technique. So in conclusion, early detection of hearing loss is important. Identifying hearing loss in young children. I support a trial of early intervention. It's important to monitor the hearing and academic success of these children. Bone conductors are a must in children with oral atresia in both ears. The benefits are unclear in children with atresia in one ear. It's important as parents that you know all the options for hearing health for your children. Surgery for canal surgery is technically very difficult, and patient selection is critical. As you go down this road, you will find what is right for your child and will make good decisions based on good information. So we made it through this talk together, and I thank you very much for your attention, and I thank Hong Yan for his invitation and invitation from Dr. Fong and the folks at Unicare, and it's been my pleasure and my honor to present this discussion.